Hello everyone. This presentation will discuss first, second, and third order bends. These bends are primarily used for the optimum finishing of the occlusion to achieve a high standard orthodontic treatment outcome. These bends are critical components of standard edgewise appliance. In pre-adjusted edgewise appliances, the effects of these bends are inbuilt in the brackets. However, for many patients, these inbuilt effects may not be optimum. Thus, additional effects by putting various bends in the arch wire are often needed for better finishing of the occlusion. An orthodontist needs to understand the importance of these bends for optimum treatment results. First order bends are various bends in the arch wires that cause tooth movement in the x-axis. First order bends are also known as in and out bends. They cause labiolingual or buccolingual tooth movements. First order bends also cause rotational movements. Second order bends are various bends given in the arch wires that cause tooth movement in the y-axis. Second order bends are tip bends that bring tooth movements in the mesiodistal direction. Third order bends are bends given in the arch wires that cause tooth movement in the z-axis or in the axial direction. Now, we will discuss first order bends in detail. You all know that the labiolingual thickness of various teeth is different. Thus, first order bends aim to contour the arch wire to the labial or buccal surfaces of teeth, which vary in their labiolingual thickness and do not conform to an arch. The extent of each first order bend is dictated by the labiolingual thickness of individual teeth so that a smooth curve of incisors and canines on their lingual surface can be achieved. First order bends can be put both in round and rectangular arch wires. The effects of the first order bends result in mild contraction and expansion of the dental arch. In the maxillary arch, lateral inset, canine eminence, and molar offset are typical first order bends. However, canine eminence and molar offset are typical first order bends in the mandibular arch. Also, in a few cases, the mandibular arch requires premolar offset. The labiolingual thickness of the maxillary lateral incisor is less compared to the central incisor and canine. Thus, a lateral inset in the arch wire is required for the maxillary lateral incisor to compensate for its labiolingual thickness. The labiolingual thickness of the canine is more relative to the lateral incisor and its position is more labial in the dental arch. Thus, a canine eminence is required in the arch wire for canine. Molar offsets are critical components of first order bends. A molar offset between premolar and first molar is also known as anti-rotation or toe-in bend. The severity of this bend varies from case to case. Look at the picture in which the left side mandibular first molar is mesiolingually rotated. Such a problem can easily be corrected by simply putting a molar offset in the arch wire, as shown in the picture. After putting the first order bends in the maxillary and mandibular arches, the arch wires must be coordinated to each other. When the arch wires are coordinated with each other, as shown in the figure, the gap between the maxillary and mandibular arch wires in the incisor and posterior region should be approximately 2 mm. Look at this picture. You can identify the differences in the base thickness of various pre-adjusted edgewise appliance brackets. Such differences in the base thickness are primarily to achieve the first order effects in the dental arches when a plain arch wire is ligated. Thus, in pre-adjusted edgewise appliances, first order effects are incorporated in the bracket and molar tube bases by varying their base thickness. However, in many cases, additional first order effects may be helpful to achieve better finishing of the occlusion. Now, we will discuss second order bends in detail. Second order bends in the arch wire are the bends in the occlusal gingival direction, which help to achieve or maintain the final mesiodistal angulations of teeth. In the maxillary incisor region, second-order bends are called as artistic bends and are given to achieve the ideal angulation of incisors. Second-order bends are also used for root paralleling. Second-order bends can be given both in round and rectangular arch wires. Look at these pictures and remember how maxillary and mandibular arch wires with second-order bends look. Remember, the first bend in the second-order bends is the V bend. The apex of the V bend is always directed gingivally. After putting the second-order bends in the maxillary and mandibular arch wires, they must be coordinated to each other. When a continuous arch wire with second-order bends in the posterior region is ligated in the maxillary arch, it produces palatal root torque in the incisors, which is favorable. However, it also causes their labial crown movement. This unfavorable labial crown movement of the incisors can be prevented by using class 2 elastics. Meanwhile, in the mandibular arch, second-order bends in the posterior region produce an unfavorable labial crown movement of incisors. Also, second-order bends in the posterior region cause intrusion of the anterior teeth. This helps in the correction of deep bites. But when the overbite is normal, it may lead to the development of anterior open bite. Thus, anterior box elastics should be used to prevent the development of anterior open bite. In the posterior region, second-order bends maintain the distal tipping of the premolars and molars and cause bite opening. This type of bite opening is called a pseudobite opening. The bite opening is primarily due to the elevation of the mesial marginal ridges of posterior teeth. Now we will discuss V-bends. Remember, V-bends are prepared first before putting other second-order bends or tip-back bends in the arch wire. These V-bends differentiate the anterior segment of the arch wire from the posterior segment. You know that the nature of torque in incisors is different from the rest of the teeth in the dental arch. Thus, V-bend act as a neutral zone by separating their torque in the arch wire. Also, V-bend act as a site for the soldering of attachments like intermaxillary hooks to the arch wire. The apex of the V-bend also guides clinicians in identifying the gingival and occlusal surfaces of a rectangular arch wire. Now, we will discuss different types of second-order bends. There are two types of second-order bends given in the arch wire. The first one is short second-order bends, which are typically given in the arch wire to achieve the normal mesodistal angulation of the teeth or for the preparation of anchorage. Short second-order bends are given at the midpoint of interproximal areas. Long second-order bends are given during the extraction space closure and are given just distal to the brackets so that the arch wire can slide to a greater distance between the brackets. In many clinical situations, we incorporate bends like second-order bends, tip-back bends, and bite-opening bends in the arch wires. So, you must understand the differences between them. Second-order bends are typically used to achieve or maintain the normal mesodistal angulations of the teeth. These are typical finishing bends. Tip-back bends are basically exaggerated second-order bends. Tip-back bends cause significant distal tipping of the posterior teeth and mesial marginal ridge elevation. Tip-back bends are given in the arch wire for anchorage preparation. Bites opening bends in the arch wire include tip-back bends along with the curve of SPE in the upper and reverse curve of SPE in the lower arch wire. Bite opening bends help to open the bite by extrusion of the teeth in the middle segment of the dental arch. In the pre-adjusted edgewise appliance system, second-order effects are incorporated in the brackets by changing the angulations of bracket slots. But additional incorporation of second-order effects by putting the second-order bends in the arch wire may be useful in some cases to achieve a better finishing of the occlusion. Now we will discuss third-order bends, commonly called torque. Torsional bends along the long axis of the rectangular arch wire are called third-order bends or torque in the wire. The aim of third-order bend or torque in the wire is to achieve the root movements. Depending on the type of root movement, there are two types of torques. The first one is palatal or buccal root torque, and the second one is palatal or buccal crown torque. Look at the picture in which appropriate twists in the maxillary and mandibular arch wires have been incorporated for desired torque in the incisors. The twist in the maxillary arch wire, as shown in the picture, will result mainly in palatal root movement of the maxillary incisors with very little labial crown movement. Similarly, the twist in the lower arch wire will result in mainly labial root movement with a little amount of lingual crown movement. Remember, during torquing movement, purely crown or root movements are practically impossible. A lingual root torque always produces some amount of labial crown torque. Similarly, a labial root torque produces some lingual crown torque. This is because when a twisted rectangular arch wire is engaged into the bracket slot, a moment of the couple is generated and its center of rotation remains inside the bracket slot. As the root apex is far away from this center of rotation, more root movement occurs compared to crown movement. Now we will discuss the difference between active and passive torque. When a torque in the arch wire can affect the movement of a single tooth or a group of teeth in the dental arch, it is called active torque. That means the arch wire is capable of exerting a sufficient amount of force to bring the tooth movement. In contrast, when a torque in the arch wire is not sufficient to produce tooth movement after its full engagement, it is called passive torque. The passive torque in the arch wire is to maintain the already achieved tooth movement. Another thing is that the torque in the arch wire may be continuous or progressive. In continuous torque, the whole segment of the arch wire has nearly the same amount of torque. However, in progressive torque, the severity of the torque progressively increases in the arch wire. Continuous torque is recommended in the maxillary posterior and mandibular incisor region, whereas progressive torque is recommended in the mandibular posterior region. This table describes the normal inclination of the teeth in the maxillary and mandibular arch. The buccal root torque of the maxillary canine and all posterior teeth is nearly the same. Thus, a continuous buccal root torque is applied in the maxillary arch wire distal to the V-bends. In the mandibular arch, the buccal root torque of all the teeth from canine to second molar increases progressively. Thus, a progressive buccal root torque is applied in the arch wire distal to the V-bends in the mandibular arch. Let us now discuss how to quantify the torque requirement for a patient. Remember, the inclination of incisors depends on the vertical growth pattern of a face. In contrast to normodivergent individuals, the upper and lower incisors are relatively upright among hyperdivergent individuals. Similarly, in hypodivergent individuals, the upper and lower incisors are relatively more proclined. Thus, it is essential to quantify the exact amount of torque required for a patient so that you can apply the torque accurately in the arch wire. In our day-to-day clinical practice, we quantify the inclination of upper incisors from a few cephalometric parameters like upper incisor to SN plane, palatal plane, and NA line. If the values from the upper incisor to the SN plane and NA line are less and the upper incisor to the palatal plane is more, then we consider that the upper incisors are under-torqued. However, these parameters are greatly influenced by the inclination of SN and palatal planes, thus masking the exact inclination of upper incisors. Previously we discussed that the upper incisors' normal inclination depends on the vertical growth pattern of face. When the inclination of the upper incisors is normal, then the long axis of the upper incisors should parallel with the facial axis and condylar axis. Due to the differences in the growth pattern, the incisors are slightly upright among hyperdivergent and proclined among hypodivergent growth pattern individuals, which are typical to their facial patterns. Thus, the requirement of torque must be quantified concerning these two planes. Quantifying the inclination of the upper incisors concerning the SN plane, palatal plane, and NA line can misguide a clinician in quantifying the torque requirement. Now let's discuss how to clinically check the archwire's torque. Look at the right side picture. When an archwire with palatal root torque is engaged into the bracket slots of incisors, the posterior segments of the archwire remain above the bracket's slots level of the posterior teeth. The angle between the bracket's slots level of posterior teeth and the posterior segment of the archwire is the amount of palatal root torque present in the archwire. Similarly, when an archwire with buccal root torque is engaged into the bracket slots of posterior teeth, the other end of the archwire remains in the vestibule as shown in the picture. The angle between the bracket's slots level and the opposite side archwire is the amount of buccal root torque present in the archwire. Achieving normal inclination of the teeth during comprehensive orthodontic treatment is very crucial for optimum treatment results. In pre-adjusted edgewise appliances, torque values are inbuilt in the brackets. However, an additional torque in the archwire may be beneficial in few cases for optimum finishing of the occlusion. In pre-adjusted edgewise appliances, torque values are inbuilt in the brackets. It means the torque values are either adjusted in the base of the bracket or face of the bracket, or both. We will discuss identifying whether the torque is present in the bracket base or bracket face. Also, we will discuss the clinical significance of torque in the bracket base and face. Let us discuss various criteria to identify a standard edgewise or zero torque bracket. In a standard edgewise bracket, the long axis of the bracket stem and the long axis of the bracket slot are parallel to each other, and they are perpendicular to the bracket base. The slot's midpoint, known as the slot point, and the middle point of the bracket base, called the base point, remain on the one plane. In pre-adjusted edgewise brackets, torque values are integrated either in the bracket base or bracket face or both. The first picture is a standard edgewise bracket in which torque is 0. The second picture is a pre-adjusted edgewise bracket with built-in torque in the bracket base. The third picture is also a pre-adjusted edgewise bracket, but the torque is built-in in the bracket face. Look at the middle picture. In that bracket, the torque is integrated in the bracket base. When the torque is integrated in the bracket base, the stem of the bracket remains parallel along the long axis of the bracket slot. Also, the slot and base points remain in one plane. Look at the last picture. In that bracket, the torque is built-in in the face of the bracket. When torque is built in the bracket face, the slot is cut at an angle to the bracket stem. As a result, the long axis of the bracket slot does not remain parallel along the long axis of the bracket stem. Also, the slot and base points remain at different planes. Now, let's discuss the clinical significance of torque in the base. In straight wire appliances like Andrews and Roth prescription, the torque is built-in in the bracket bases. When the torque is built-in in the bracket base, remember the bracket should be bonded at the facial axis point or far point of the clinical crown of a tooth. As shown in the figure, the far point on the clinical crown of a tooth and the base and slot points of a bracket should be in one line while placing the bracket during bonding. Now let us discuss the clinical importance of torque in the face. In many pre-adjusted edgewise appliances like MBT and Alexander prescriptions, torques are built-in in the bracket face. When the torque is built-in in the bracket face, placing the bracket at the facial axis point or far point of clinical crown is not mandatory. As shown in the picture, the recommended height for bracket placement can be followed for placing the brackets during bonding. Remember, the facial axis, base, and slot points may or may not remain in one line. Thank you very much for watching this video.